Okay, kia ora everyone. So this webinar is focusing on supporting people who struggle to quit smoking. And I'm sure that, like me, you have a number of these clients from time to time. And I'm afraid there's no one-size-fits-all answer to this, certainly no easy solution. But I hope we can just go through this step by step and pick out some of the issues that may need to be addressed or at least acknowledged. And I had put some pictures in here to make this a little bit more interesting, but instead you've just got the quotes on this version. I'm not quite sure what happened, but here are some situations that may be familiar to you all. And this is, for example, where you get a client that says, I'm only here because my GP sent me, or I'm only here because I just want to get my GP off my back. And as you know, primary care are trying their best to prompt people to quit smoking and use support. But what do you do when you get these sort of people? Say, oh, you know, I'm not really here. I don't really want to stop smoking, but just here because of this. And my response to this is always, well, you know, they turned up because they could equally just say when you call them, no, I'm not interested. And so I think there's an opportunity here just to use the time to sell your treatment, your information, whatever you've got, in a quick and easy way. I know the easier thing is just to say, well, you're obviously not ready, so see you later. That's it. But use the time, sell what you've got. And what I would normally do too is say, well, look, if you're not interested now, can I give you a call back? Now, marketers do this all the time. You'll sign up for something, and then every single month you'll get a call from someone trying to sell you Central Otago Chardonnay or something like that, even though you may not want it. They're there trying to sell it to you. And I think that we could work in this way as well. So if you've got someone that may not be interested right at this moment, ask them, so when would be a good time to call you back? Or would it be okay if I call you in a month to see how you're going? And if they say yes to that, you know, schedule that into your system for a call back. I think it's a way of just staying in touch. Another one you might see is like, yeah, I know I should give up, but I really enjoy smoking. I really love it. I'm really going to miss it. And I think that this is quite a common situation. And you know, if any of you have smoked, you know you might have a fond memory of smoking. Look back and think, yeah, that was nice. It was enjoyable. There are times when it really did help me feel like I was relaxing, or it filled this need. And I think arguing with people about this is absolutely pointless. And I usually acknowledge that, yeah, lots of my clients say this. You could then move on to say, well, you know, why is it that you're thinking about quitting? And this is where you can use some of those motivational interviewing skills that we talked about in the last webinar. That you might have to work a little bit differently with these people. They may not be right on that button of wanting to quit today, and you might need to explore some of their reasons, some of their barriers, and get them to come to that decision themselves that now is going to be a good time to quit. Another situation you might hear.
Sorry, can I just drop in with a question?
Yep.
So what do you say to people who say, I would quit, but when I quit, I just stress out? Smoking helps with my stress. It's my stress relief. Yeah,
good question. And we all face that one. I usually say something along the lines of, yeah, that's really common. And it can be difficult when you first quit smoking. And it's similar to a lot of the other withdrawal symptoms that people get. And it takes some time for your mind and brain to adjust to a life without smoking. But it is possible. It can have its ups and downs, but we'll be here supporting you along the way and help to get to that point where you'll have other mechanisms by which you cope with stress. Cutting down issue. I think this is for some people, they think, yeah, actually good, I've cut down. This is where I need to get to. And sometimes it's a little bit of a defense. Other times it's acknowledgement of that they are struggling. And I think this is a chance to explore their ultimate goal. Now, if I jump to the last bullet point there, there is an important rationale of quitting completely. This is the monster on your shoulder, you know, feeding it just a little bit every now and then. The monster's still there. And there needs to be an ultimate goal of quitting smoking completely. And I think you can probably explore with most clients times in the past where maybe they've stopped and just one cigarette was all it took for them to go back to regular smoking. It's actually quite hard too for many people to stay on a reduced cigarette consumption. It takes a lot of energy. They're starting to stretch out their times when they don't smoke. And actually it would be easier just to get to the point where they don't smoke at all. So hopefully that's their goal in mind. You might be using a cut down then quit approach. And so I think, you know, check that they're using medicine to help support them do that. Cutting down on their own without any nicotine replacement therapy or Champix is tough work, and people tend to compensate. So explaining the rationale of why medications can help them cut down better than just doing it on their own can be really important and really useful.
Can you just explain what you mean by compensating?
So when people cut down, they typically smoke their fewer cigarettes differently. For example, they might take larger puffs. They could hold those puffs down longer, so that gives time for more nicotine to be absorbed. And they typically smoke more of their fewer cigarettes as well.
So if someone is smoking, say, 15 a day, and they cut down without using medicines to, say, 4 a day, from those 4 cigarettes, are they getting an equivalent amount of nicotine that they would have got from their 14 or so?
It's likely that they're compensating enough to maintain very similar blood nicotine levels to when they were smoking 14 a day. People typically get down to a point where they can no longer compensate. You can only get so much out of your cigarettes and the time that you spend smoking, which is why a lot of people say, well, I really struggle to get under your 4 cigarettes a day or whatever it is. You know, they've got to a point where they can no longer compensate for those fewer cigarettes.
Okay, so that's the problem with cutting down to quit without any medicines.
That's correct.
So much nicotine.
Yeah, and the rationale for using something like nicotine replacement therapy is you're still giving them the nicotine, and so they don't have to compensate so much from their fewer cigarettes.
Okay, great.
Other situations, I'm trying, but it's just so hard. I just can't get off those, or I really struggle, you know, with the stress in my life. Again, this might be quite a common thing that you hear. And there are a few points just to cover off. I know this sounds a bit like a broken record, but it is important to acknowledge that, yeah, it can be difficult. You've probably seen other clients that have gone through the same thing. So I think it's important to share that with people, reiterating that this is part of tobacco dependence and withdrawal. Their brains, their minds, their body are so used to regular doses of nicotine from tobacco smoke that these changes are difficult. But you can reassure that over time, it will get better. It may take some time, but if you can stick with it, and again, you can talk about that monster on the shoulder, people do get that, and it does help them understand the rationale for getting to a point where you're quitting smoking completely and then doing everything they can not to have a single puff.
And can you just, I've heard you talk to people and say that it's really important to praise people on past quit attempts, no matter how short they've been. Can you explain why that is and how you do that?
Yeah, I think you want to give people a little bit of motivation, and a lot of people feel that, you know, when they've quit multiple times before, they've failed. But it's not so much that they've failed or they've got no willpower. It's just that they're very dependent on tobacco. And so any length of time quit is a good thing. And I think it's important to remember that, you know, most people that try to quit smoking don't even get through the first day. So, you know, giving people a little bit of hope that this is possible, I think is a really important step.
And why do you talk about being dependent on tobacco rather than being dependent on nicotine?
Yeah, that's a really good question, Grant. And I try and separate this a little bit for a couple of reasons. One, people get very anxious about using nicotine replacement therapy when you talk about just nicotine addiction, even though that's primarily what they're dependent on is the nicotine. But there are other substances in tobacco smoke which might potentiate the addictiveness of tobacco smoking. So certain substances that increase the amount of time that dopamine remains in your brain present in tobacco smoke, other things that might potentiate the addictiveness of nicotine. So, remember that tobacco smoke is not just a nicotine delivery vehicle. There are a whole lot of different things in there that perhaps we don't fully understand, but we know that some substances are likely to produce dependence over and above nicotine. Okay, a question that often comes up, are smokers getting harder to treat? This is kind of this hardening hypothesis. And this sort of goes that as the smoking prevalence declines, as we have less people smoking in our communities, those that are left are either unwilling or unable to stop smoking. And these smokers are often referred to as hardcore. Actually, just on that note of definitions, in days gone by, hardcore were really the people that just didn't want to stop smoking. I'm not going to do it at all, have no interest. They were sort of the hardcore, as opposed to those that are just really struggling to quit smoking. But this has sort of merged more recently. Now, this often comes up, and there's often debates with people in the tobacco control sector about this. And the data's, it depends on what you look on, and it depends on your definition of hardcore smoking. Now, often one of the definitions that are used is just the phagostrom test for nicotine dependence, or the number of cigarettes smoked per day. And if you look at just those things more recently, that say, well, actually, we're not really seeing people that are left that are really smoking many, many cigarettes, which is what you'd expect, right? If you were just left with those that are really hardcore, they'd still be smoking 20 cigarettes a day. But what it doesn't take into account is the fact that there are other pressures on people to reduce their cigarette consumption. You can't smoke in a whole lot of different places. Cigarettes are becoming really expensive. And you know that people are deconstructing their cigarettes, taking one to make three. So, they still might count the one cigarette a day because that's the one that they've pulled apart. So there are things that may not be as clear-cut as we think. But let me just show you what is often the characteristics of these hardcore smokers. They typically are older, single men from socially disadvantaged backgrounds. They started smoking at a really early age. They don't have that much contact with health professionals and are less likely to have smoking bans in their, sorry about the spelling error there, in their homes. So this is typically what they've seen, but most of these data are relatively old now, and I think this picture's probably changed a little bit. And if I can just show you an example of a change in dependence by smoking prevalence. So this is where we're talking about the smokers left may be more dependent. But again, these are quite old data now, over 10 years old. But what this graph is showing you is that as the smoking prevalence shown here decreases, okay, then those that are left typically have a higher dependence score. And this is the Fagostrom test of nicotine dependence. So you can see there, in countries that have a lower smoking prevalence, they tended to have higher dependence levels. But of course, the FT&D score is based, it's a score of 10. So we're talking about still relatively low levels. Another way to look at it is just looking at decreasing quit rates in studies of behavioural treatments, as shown here. Again, quite old data, but over time, here's the year of the study published, back in the 1970s, right to sort of the late 90s. You can see that over time, the quit rates reported in these studies has decreased as well. So that also might be an indicator that the people left are harder to treat, or they've got lower quit rates. So it might be an indication actually that the people left that are still smoking are really struggling. And if you're looking at pharmacological treatments, so the previous slide was behavioural, these are studies of, in this slide, nicotine gum, and you can see the same sort of picture. Now, there'd be no good reason why nicotine gum would be less effective in the 1980s versus the 1990s. So it seems to be that the people are changing, and perhaps those that are still smoking later on are your more highly dependent smokers. And this I just wanted to show you just a point on compensation here, or the relationship between cigarettes per day and plasma cotinine. Cotinine, of course, is the main metabolite of nicotine. Now, if you look at those less dependent smokers, just at the bottom here, so this is time to first cigarette over 30 minutes. You can see more generally that if you smoke fewer cigarettes, you have a lower blood nicotine level, and if you smoke more cigarettes, you have a higher blood nicotine level. Okay, so more of a kind of linear relationship there. But if you look at your most dependent smokers, those that smoke within the first 30 minutes of waking, there's very little difference by number of cigarettes smoked per day. Okay, even those that are smoking less than 10 cigarettes a day still have higher plasma cotinine levels. And this is why a lot of our guidance is based on time to first cigarette. We're a little bit more liberal in New Zealand. We use smoking within the first hour of waking, but you typically get a better picture. So number of cigarettes smoked per day is less of a good indicator of blood nicotine levels than time to first cigarette is.
So just on that slide, Hayden, would you be able to explain what a metabolite is and how you measure cotinine?
So cotinine's measured, can be measured in blood, it can be measured in saliva, it can be measured in urine. And nicotine is broken down by enzymes in the body quite quickly, and it's broken down to form cotinine. So that's what a metabolite is. It's sort of a byproduct. Cotinine stays around for much longer though. So it gives an indication of how much someone smoked, better than nicotine does, and certainly better than carbon monoxide as well.
Okay, thank you.
Failed quit attempts. We're probably seeing more people now that have made lots of failed quit attempts in the past, and I think that this is probably an aspect of dependence. The more you've tried to quit and failed in the past, then probably the more dependent you are. And if we're looking at smokers who made 2 or more quit attempts in the last year compared to those who only made 1, they were actually more likely to try to quit again, but less likely to succeed. And so if you're seeing people that have made many quit attempts in the past, they're probably the people you need to wrap a little bit more support around. Which brings the question, this whole quitting fatigue thing, and I'll come on to this at the end. For some people, quitting too often may not be a good thing. It may be better for some people to have a little bit of a break, but I'll touch on that in a minute. So what does this all mean for us? I think it's about us thinking carefully about people who smoke, where they come from, their age, their comorbidities, that is other diseases or illnesses that they have, the number of previous quit attempts. And again, making sure we capture the most highly dependent smokers. Time to first cigarette is a really good way of doing this. And your most highly dependent smokers are really going to need good multi-session face-to-face services. So trying to get GPs to make sure that they refer these people in particular, and that's especially true for those with mental illness or other substance abuse or misuse. In terms of medications, bupropion and varenicline are both fixed dose, but remember NRT can be tailored. And I just want to reflect back on the Ministry of Health guidelines for this. You can Google these if you've forgotten where they are. But those guidelines, if you follow those through, most smokers end up starting on full strength patch plus full strength oral product. And the guidelines do let you increase that dose if people are still experiencing urges to smoke. So that's a small note under that flow diagram. So they're quite flexible, and we're quite lucky in this regard. Underdosing, you all know this, and do check back on our nicotine replacement therapy webinar as well, where we talk about underdosing and using NRT better. But even when you're using combination treatments, most smokers don't obtain the same nicotine levels that they get with smoking. So don't be afraid to use more here. I think a stepped approach is the most effective way to do this. It's really difficult to know who might need 2 patches, for example. So I would recommend starting with the Ministry of Health guidelines and monitor their urges to smoke and other withdrawal symptoms. That's partly why we check on those things. And if they're still struggling and craving, then agree with them to increase your dose of NRT. But you also want to watch out for side effects as well. And remember, if people get too much nicotine, they're going to feel a little bit sick. And if that happens, you can reduce the dose.
So just on that, just remind us, how many high strength or 21 milligram patches can a highly dependent smoker use before they're going to feel a little bit sick?
There's no hard and fast answer to that, unfortunately, Grant. You've got to tailor the dose to the person. So some smokers might cope with 4 full strength patches, even 5 full strength patches. Other smokers may not tolerate more than 2. So this is why a stepwise approach is really important. You can't go on and think, this person smokes 20 a day and smokes within the first 30 minutes of waking, so they need 4 full strength patches. They may not. And there are other things involved as well. That's not just about the nicotine. Yeah.
So what will people say to you when they are experiencing too much nicotine from NRT products? What do they report?
Most of them would say, I feel a bit sick, or I've got a bit of nausea. That's most likely what they say. But actually, it's not very common, Grant. Most people tolerate quite high levels of nicotine.
Okay. Thank you.
Yeah. I just want to make a point about the patches. Remember, our subsidised patches are the 24-hour patches. They're designed to be left on overnight. Leaving them on overnight actually may have better craving relief in the morning, and it doesn't necessarily cause sleep disturbance. And again, I want to refer you back to our NRT webinar. So don't race out there to advise everyone that they're going to cause nightmares or sleep disturbance when sleep disturbance is a relatively common tobacco withdrawal symptom as well. So, use the patches how they're designed to be used, which is overnight. And look, if people are really, really struggling with all sorts of nightmares, try them off overnight, but it may just be that this is part of tobacco withdrawal and not a side effect of the patch at all.
So because they're stopping smoking, it's a withdrawal symptom that the sleep is disturbed and the dreams are waking them up in the middle of the night, yeah? And remembering them more vividly. It's not because they're using patches often.
No, true, yeah.
Okay.
Okay, and I just want you to remember, it's not just all about the nicotine. I know it's easy to focus on just patching people up to the brim, but there are other things to consider. And this is where our role as, stop smoking practitioners is, this is what we add. And we look at the other things associated with smoking, the so-called secondary reinforcers, the drinking your morning cup of coffee, the alcohol, the stress, the socializing. Is smoking a coping mechanism for the people that you're seeing? If it is, what are you going to put in place when they're no longer smoking? And we need to take these approaches just a little bit more methodically to make sure that we're giving people the best chance of quitting. For some, the behavioural aspects of smoking are going to be important. The taking the puff, the hit in the back of the throat. And if these are important, maybe vaping may be a helpful option for people. So try and just be a little bit smarter in terms of how you tackle all of this. It's not just all about loading people up. I think for some people, you could give them 5 full-strength patches and they'll still smoke, because their main driver for smoking might be stress or socializing. So those things are important to tackle as well.
Hey, there's a few questions come in, Hayden, via the chat function.
Okay.
So
how about we just, I've just got a few more slides that I...
Okay, yeah, okay, so we'll come back to those as soon as you're done with the slides.
Yeah.
Great.
So, just different support for different people. You may need to consider extending the length of your program. For some people, it may not be the length of the program, it may be the frequency of the support you provide. So for some, getting in touch with them every other day might be the way to do it. And this could be via text or email. There may be a bigger pre-quit period where you're helping people cut down, then quit. And you need to be doing that with medication. It may be that you take a sort of a preloading approach. So this is not where people are actively cutting down, but you say, right, here's some patches to use before quitting, and you can just smoke as normal. The idea here is you're trying to uncouple the reward from smoking with the nicotine delivery. And I just want to point out too, you also need to manage your time carefully. And you'll have some people that are raring to go and ready to quit. So you've got to allocate enough time for all of those people, whilst also managing these people that do struggle to quit. And I think at times you might have to call it quits with them. I think ongoing struggles may deplete motivation. They just feel like it's harder, it's getting harder and harder, they just can't do it. Sometimes it may be better to take a break and start again when your client's ready. But don't leave the ball in their court. Ask them when they want you to give you a call and to start again. And you need to be flexible here. Again, wait. So just to cover off in summary then, some people do struggle to quit for reasons such as high dependence, that it's has a whole lot of habits associated with it, and it may be a coping mechanism for some people. There's just no one-size-fits-all approach for how you deal with these people, but don't be too quick to give up or give in. So use the tools that you have, support people to become smoke-free. Sometimes this is going to take some time, but you need to manage your time too, to stay sane sometimes and not feel like you're not making any difference. And finally, it is okay sometimes to suggest some people take a break and to come back when they're ready. And that was that.
Excellent. Okay, we'll run through that chat function questions. So first question is talking about multi-patch use and nausea. So wouldn't you also need to check that they are not smoking if they are feeling nauseous during this process?
Yeah, I think Tano, you're right. If you're doing that in a way where you're loading people up with nicotine replacement therapy prior to quitting, and they're feeling nauseous every time they have a cigarette, that may not be a bad thing, and that's a really good driver to stop smoking completely. But it would also be a sign to think that actually your nicotine level, the replacement level of nicotine, is probably pretty close to what you need. And just another question there I see. I've had some clients who have become severely constipated after quitting, so I've needed to update my nutrition knowledge. Do you have any ideas that may help? Yeah, constipation is a tobacco withdrawal symptom. It's something that people don't often talk about for obvious reasons, but it is important to address. And I just, routinely at the front say, look, some people do report constipation, so make sure that you stay hydrated. And if people are having troubles there, then simple things like high fiber diet is a really good place to start. But if it's severe, you can refer them to their pharmacist, usually as a simple place to get some good advice.
I've got a question, and then we'll open it up to the floor. Have you ever seen a client who's using lots of full strength patches and smoking and who has severely overdosed on nicotine?
No.
No. Why is that?
I think it's just because most people, most people who smoke are quite used to the adverse effects of nicotine and are already getting quite high doses. We don't really get into the areas of nicotine dose with most smokers that would put them into that category. Even with some of the studies that have used high dose patching, for example, 5 full strength patches in non-smokers, that can make non-smokers pretty sick, but we don't usually get to those points with people who smoke.
All right. Thank you. So what I'll do is I'll unmute everyone. So if you do have any questions for Hayden, now is your chance. Just a warning, if you're having an early Christmas party in your office, everyone's going to be able to take part. So ask the revelers to take it outside, and I'll unmute you. So if you have a question, now is your time. Okay, you're all live.
Hayden, just going to ask a little bit about the vaping as far as the habits go. Obviously, what's been in the press lately, we've become pretty gun-shy, if you like, about recommending any vaping. Yeah. What's your thoughts on this?
Look, we've got to not panic over this. So the main reports have come out of the US, where there have been, I think it's 8 deaths associated with vaping THC containing liquid. Okay, so we're not talking about e-liquids that people have been using over the past 10 years. So it seems to be specific, related to some contaminant in certain liquids for using THC. That's the main active ingredient in marijuana. So I think the message here really is, don't go buying your capsules or your liquid or something off the street. Make sure that you are buying them from a reputable dealer. These are for people who smoke. They're not for people that don't smoke. I think if we stick to that advice, then that's following the current ministry guidelines.
Thank you.
So are you saying that people have been affected by using counterfeit
pharmaceutical grade products
and smoking other substances other than nicotine in them?
Struggling to find anyone.
So yes, the cases out of the US, which have been quite a large number, around 400 of severe lung disease, they've said associated with vaping. But it's not the vaping per se, it's what you put in the vaping product.
Sorry, we've lost you.
I think there's just some background noise, Grant.
Are there any other questions on the floor? No, I think that looks like it, Hayden.
Okay.
So thank you very much for that. And would you like to end on anything? Or?
No, but keep going with your highly dependent.
Right.
Because those that struggle to quit, Edward Cowling, you're making a noise on the line, and stick with it. It's really rewarding at the end of the day. Clients.
Sorry, Hayden, we've lost you. I think I'll have to mute everyone while you finish up, eh?
That's okay. I'll say goodbye to everyone.
Sorry, repeat that. We missed you.
Bye, everyone. Thanks very much. See you in October.
Excellent. We'll edit that bit out.
Yeah, good.
Good to see you again. Thank you, everyone. Thanks for attending.